Yeah, there are a variety of factors that kind of play into the decision of intensive versus non-intensive therapy. Um, One of the key factors is the degree of fitness and number of comorbidities affecting patients, so that patients who are considered more frail on the basis of performance status or other coexistent medical problems like underlying heart disease, lung disease, kidney disease. Um, Patients with those types of problems are more suitable for an HMA venetoclax lower intensity approach than more intensive induction chemotherapy. You can also consider age over 75 as being a factor favoring lower intensity therapy. When it comes to the disease biology, we often use the ELN risk stratification as a guide for intensive versus low intensity therapy in older patients. So, for example, if a patient has a favorable risk leukemia, such as a core binding factor leukemia, or perhaps an NPM1 mutated leukemia, those patients would be more strongly considered for more intensive induction chemotherapy than, for example, a patient with higher risk biologic features such as um, loss of chromosome 7 or loss of chromosome 5 or adverse genetic mutations such as are outlined in the ELN 2022 risk scoring system that include MDS related mutations and things like that. So I think the biology of the disease being favorable would have an influence on the decision for intensive induction therapy versus lower intensity therapy. Um, and those are I think, the two major considerations when it comes to deciding intensive versus non-intensive approaches.